Good morning to all. Today's topic is on mucogingival surgery. Learning outcomes are identification of various types of mucogingival problems, discuss the problems associated with mucogingival defects, determine the etiological factors for recession and identifying the type of recession based on various classifications, decision making on the various clinical presentations of mucogingival problems. Selecting the treatment procedures in localized root exposure due to recession, planning of lateral pedicle graft, planning of free-gingival grafts, selection of the techniques of increasing the zone of attached gingiva and vestibular, discuss frenectomy and frenotomy procedures, identify the indications and contraindications of crown lengthening procedures, list the factors to be assessed to select the crown lengthening procedure, select the suitable crown lengthening technique for the given scenario. So, what is mucogingival surgery? It was initially introduced in the literature by Friedman in 1957 to describe surgical procedures for the correction of interrelationships between gingiva and oral mucous membrane, with special reference to three problem areas. They are attached gingiva, shallow vestibules, and a frenum interfering with the margin gingiva. So, with the advancement of periodontal surgical techniques, the scope of non-pocket surgical procedures also have been increased. So, and now encompasses a multitude of areas that were not addressed in the past. So, coming to the problems related that here you can see the picture that is associated with the mucogingival problems, that is frenum interfering with the margin gingiva, with the shallow vestibule, decreased width of attached gingiva. It leads to the recession of gingiva. So, the World Workshop in Clinical Periodontics in 1996 renamed mucogingival surgery as perioplastic surgery. There is a term originally proposed by Miller in 1993 and broadened to include the following areas. So, they are periodontal prosthetic corrections, that is perioprosthetic surgeries, crown lengthening, ridge augmentation, aesthetic surgical corrections, coverage of the denuded root surface, reconstruction of papilla, aesthetic surgical correction around implants, surgical exposure of unerupted teeth for orthodontics. So that is why periodontal plastic surgery is inclusive of all surgical procedures to prevent or correct anatomic, developmental and traumatic or plaque in disease-induced defects of the gingiva, alveolar mucosa or bone. So coming to the differences between, so why it is different from mucogingival therapy? There is mucogingival surgery, that is according to AAP, American Academy of Periodontics. So they defined this mucogingival therapy as a broader term, that is it includes both non-surgical and surgical correction of the defects in morphology, position or amount of soft tissue and underlying bone. For example, for including this mucogingival therapy, they have included the restorative, whether it's orthodontic or restorative therapy for use for papillary reconstruction. So it includes all the other non-surgical procedures also. Whereas perioplastic surgeries, which includes only surgical procedures of mucogingival therapy. Okay, that is, it is defined as the surgical procedures to correct or eliminate anatomic, developmental or traumatic deformities of the gingiva, alveolar mucosa or bone. So coming to the perioplastic surgeries, it has been widely classified into widening of attached gingiva, deepening of shallow vestibule, resection of aberrant frenum. These are the main problems we were accounted before. And later on, they include aesthetic surgical therapy, tissue engineering, other perioposteric surgeries, aesthetic surgeries around implants, and surgical exposure of teeth for orthodontic therapy. So later, they have included all the other surgical procedures also. So coming to the objectives of perioesthetic surgery or mucogingival surgeries are to correct problems associated with the gingiva, to correct problems associated with shallow vestibule, to treat the problems associated with aberrant frenum, and also aesthetic surgical therapy and tissue engineering. So coming to the details of the problems associated with attached gingiva. A minimal width of attached gingiva is required to maintain optimum gingival health, that you know. So this can be easily be explained by the tissue barrier concept. What is tissue barrier concept? That is a dense collagenous band of connective tissue retards or obstructs the spread of inflammation better than does loose fiber arrangement of alveolar mucosa. So always there is a need of attached gingiva. So this increased attached gingiva which helps to achieve an adequate tissue barrier. So thus that will limit the recession as a result of inflammation. Anyway, in some cases like in good traumatic oral hygiene can also maintain excellent gingival health even in absence of or in almost no attached gingiva also. Okay. So there is a good traumatic oral hygiene always important for the health of the gingiva. So a wider zone of attached gingiva is also needed around teeth that serve as abutments for fixed or removable partial dentures and in the ridge areas bearing a denture. In these cases, the techniques for widening the attached gingiva are considered pre-prosthetic periodontal surgical procedures. So if it is done prior to the prosthetic component, so it will be called as pre-prosthetic surgical procedures. So teeth with subgingival restorations and narrow zones of erect gingiva have higher gingival inflammation scores than teeth with similar restorations and wide zones with attached gingiva. So you might have understood what is the importance of attached gingiva. So always a healthy tissue should be there to protect the gingival status. So coming to the widening the attached gingiva, what are the objectives for widening the attached gingiva? As we told, that is enhances plaque removal, gingival margin binds better around teeth and implants with attached gingiva, and obviously it improves aesthetics and reduces inflammation around restored teeth. So this here you can see the flow chart. There is a lack of attached gingiva that will lead to progressive gingival recession in case of inflammation after the initial therapy. So if there is gingival recession, you have to go for mucogingival surgeries. And if no there is no gingival recession, you can see whether it is for aesthetic considerations, you can go for. So if there is no aesthetic consideration, no need of mucogingival surgeries. So the lack of attached gingiva, it can lead to osseous defect and also the periodontal pocket beyond mucogingival junction. So you can see that if there is periodontal pocket beyond it, if there is no, it can go for aesthetic considerations. If there is no aesthetic considerations, then you can go for free gingival graft, free continued tissue graft. And for aesthetic considerations, you can go for subepithelial. So we will be going to details of each techniques. Okay, don't worry. So then pedicle gingival grafts are there, and also if there is periodontal pocket, we will be going for there is for increased attached gingiva, you have to go for full thickness epigraph position flap and then flap cure attached with bone graft and with bone membrane. And if there is periodontal pocket depth, then you can go for a partial thickness epigraph position flaps. So coming to the details of the procedures, there is gingival augmentation, apical to the area of recession. So if you want to cover the gingiva, there is inadequate amount of attached gingiva, that is just apical to the area of recession. So the donor graft tissue, it can be taken from perical, that is from the adjacent one, or it can be from the parietal side. So this will be placed in the recipient bed apical to the recessed gingival margin. So no attempt is made to cover the denuded root surface where there is gingival and bone reception. So this is just the procedure that is done apical to the area of recession. The other category is that gingival augmentation coronal to the area of recession, that is basically called as root coverage. So that will be taken in the next session. Okay. So coming to the gingival augmentation coronal to the area of recession, the donor self graft tissue that can be perical or free, that is placed covering the denuded root surface. So this will be covering the denuded root, which will be increasing the width of attached gingiva and improves the aesthetics also. You can see that here there is this needed the increased widening of attached gingiva, whereas this needs root coverage procedure. So coming to the details of the procedure, there is gingival augmentation apical to the area of recession. So this can be treated by mainly three procedures. The first one, free gingival autografts, free connective tissue autografts, and then apical reposition. Coming to the free gingival grafts. So these free gingival grafts are used to widen the zone of attached gingiva. So it was initially described by John in 1963 and he extensively used that since that time. So coming to these steps each step. There is a first one, there is a preparation of the recipient site. So for example, this is the site, you have to prepare the site first. So a firm connective tissue bed is prepared to receive the graft by incising at the existing mucogingival junction with a 15 blade to the desired depth, blending the incision on both ends with the existing mucogingival line. Okay, so we will be making incisions on both sides. So the periosteum should be left covering the bone. Okay, and another technique consists of outlining the recipient side with two vertical incisions. So it can be done with two vertical incisions also, or with one incision also. Okay, anyway, they extend the incision to approximately twice the desired depth of the attached gingiva. So which will allow 50% contraction of the graft when healing is complete. So this always the amount of contraction depends on the extent to which the recipient site is penetrates the muscle attachment. So deeper the recipient site, the greater is the tendency of the muscles to elevate the graft and reduce the final width of attached gingiva. Okay. So there is what the periosteum along the apical border of the graft is sometimes penetrated in an effort to prevent postoperative narrowing of the attached gingiva. So you can see that in this picture it is giving the incisions. So extend the flap to the depth of the. So there is to the depth of the. Uh, there is it should be it should get extended to the depth of the vertical incision. So then suture the flap where the apical portion of the graft will be located with sutures. So you have to suture the flap where the apical portion is. That is. So the needle is first passes a superficial mattress. So it should be perpendicular to the incision, then on the periosteum parallel to the incisions. Okay. Then a sterile aluminum foil template of the recipient side can be used to get the pattern and to get for procuring the graft from the palate. So this graft can be placed directly on bone tissue. For this technique, the flap should be separated by a blunt dissection with a periocellator. So this coming next procedure, you can see that. See, so this apical portion will be sutured here, and an aluminum foil is being obtained to get the pattern of the material, and you can see that. See, this template has been placed in the donor site for obtaining it. So that is. For this technique, the flap can be separated by blunt dissection with a periosteal elevator. The advantages of this variant are less of postoperative mobility of the graft, less swelling, better hemostasis, and also 1.5 to 2 times less shrinkage. And however, a lag in the healing period is observed for the first 2 weeks. So you can see that the stem plate has been placed here, a shallow incision has been made to the desired thickness at one edge of the graft. Elevate the edge and hold it with forceps. Okay, again elevate it and hold it with forceps. You can see that. So then continue to separate the graft with the blade to the other areas, and graft will be removed and palate is sutured. So after the graft is removed, you have to go for the removal of all the tissue tags from the undersurface and the edge to avoid the bulbous margin and interdental contours. You can see that this graft that you have obtained from the palate, it should not be too thin or thick. So if it is too thin, what happens? That is, it is may necrose and expose the recipient. So ideal thickness it should be 1 to 1.5 mm. So proper thickness is why this proper thickness is important, because for the survival of the graft, that is, it should be thin to permit ready diffusion of nutritive fluid from the recipient side, and it should be that is essential for the immediate post transplant period. And also, if it is too thick, you can see that this peripheral layer is jeopardized. Excessive tissue that is separates from new circulation and nutrients. And also, the deeper wound at the donor site will have more amount of injury, or it will take secondary initial healing and too much time for healing. Okay, always this thick graft you can thin by holding it between the two wet sterile wooden thumb represses and slicing it longitudinally. Okay, and the submucosa in the posterior region is very thick and fatty and should be trimmed so that it does not interfere with the vascularization. Always after getting the graft from the palate, you should remove the loose tissue tucks from the undersurface. And also to avoid bulbous marginal intermediate contours. Okay, you can see that in this third step there is a transferring and immobilizing the graft. So definitely you have to remove the sponge from the recipient side, reapply it with the pressure if necessary until bleeding is controlled. Remove the excess clot, and a thick clot always it will interfere with the vascularization of the graft. You can see that this has been layered and then it's been taken out. There is epithelial connective tissue thickness. You can see that. So this will be placed here without mobilizing. So excess cloth should be removed and it should be adapted properly to the recipient site. So space, there should not be any space between the graft and the underlying tissue. The dead space should not be there, so that will again interferes with the vascularization and jeopardizes the graft. And suture the graft at the lateral borders to the periosteum and secure it in position. So this graft should be immobilized. So any movement that will interfere with healing. So avoid excessive tension also while suturing, so which can distort the graft from the underlying surface. So tissue forceps should be placed delicately and a minimal number of sutures should be used to avoid unnecessary perforations. So then coming to that is what this procedure is. That we are told that is remove the excess fluid, position the graft, adapt to it properly. So we already explained in this picture. And okay, coming to the protecting the area, so that is you have to cover the graft. So cover the graft with aluminum foil and you can go back. Okay. So there are various techniques for providing the graft from the donor. So they can be accordion technique, strip technique, and combination technique. So these following variant techniques attempt to minimize the donor site wound by removing the donor tissue in a different configuration and altering the shape to maximize coverage over the recipient site. So you can see that what are the different techniques to obtain the graft from the donor. So that is the first one, that is the accordion technique. So that is by rushing, there is expansion of the graft by altering incisions in opposite edges of the graft. You can see that they've given opposite incisions, alternate incisions in the opposite sides of the graft. See, it will be like this. So this can be stretched easily. You can see that this can be stretched easily and it can widen. So in that area, you can see that you can cover maximum amount of region where there is. You can see that. See, when it is dispersed, it can cover maximum area. And the other method is that by the strip hand, that is two or three strips of donor tissue of about 3.3 to 5 mm wide, long enough to cover. So they will be removing it into like different, they will be incising it and they will be placing it like that. Okay, so about 3 to 5 mm width if you are taken, then it will be cut down and making it in a wider length. Okay, so which helps in results in rapid healing of the donor site. Then coming to the combination of these types, so they have a combination of these two. That is, strip also can be used from the palate about 3 to 4 mm thick, and superficial portion consists of epithelium. So it can be in two different ways. Either it can be like strip wise, you can divide it, and also they can separate it as epithelium and connective tissue. Some areas you can go for epithelium and some area you can use for connective tissue. Okay. So there is minimal donor site wound by obtaining two donor tissues from one side is advantage. So coming to the indications and advantages and disadvantages. Increased width of attached gingiva, form new functional attached gingiva in completely absent attached gingiva, deepened oral vestibule for recovering exposed roots for ridge augmentation procedures. Advantages are high success rate for increasing width of attached gingiva, applicable for multiple teeth, simple procedure. What are the disadvantages? Presence of two wound areas, the unfavorable color match, the rough texture of the graft, limitations connected with the extent of the donor area, which restricts the area of gingival augmentation to 3 maximum 40th. So coming to the healing, the success of the graft depends on survival of the connective tissue. So the sloughing of the epithelium occurs in most cases, but extent to which the connective tissue withstands the transfer to the new location determines the fate of the graft. So the fibrous organization of the interface between the graft and recipient bed occurs within 2 to several days. So the first one is the fibrous organization. Then the graft is initially maintained by diffusion of fluid from the host bed adjacent to adjacent gingiva and alveolar mucosa. The fluid is transferred from the host vessels and provides nutrition and hydration essential for the initial movement of the transplanted tissues. So during the first day, the connective tissue becomes very edematous and disorganized and undergoes degeneration lysis of some of its elements. So as the healing progresses, what happens is edema will get resolved and the degenerated connective tissue will be replaced by new granulation tissue. So by this formation of this new granulation tissue, revascularization of the graft starts by the second or third day. Capillaries from the recipient bed proliferate into the graft to form a network of new capillaries and anastomos with pre-existing vessels. The central section of the surface is the last to vascularize, but this is completed by the 10th day. The epithelium undergoes degeneration and sloughing, which is replaced by new epithelium from the borders of the recipient side. So a thin layer of new epithelium is present by the 4th ray, with the retipex developing by the 7th ray. As seen microscopically, healing of the graft of intermediate thickness of 0.75 mm will get completed by 10.5 weeks, and if it is too thicker, that is 1.75, it may require 16 weeks or longer. The graft is pale and pallor changes to an ischemic grayish white during the first 2 days until vascularization begins and a pink color appears. Loss of epithelium leaves the graft smooth and shiny. Functional integration of the graft occurs by the 17th day. So coming to the next technique, there is the free connective tissue graft. So the free connective tissue autograft autograph techniques were originally described by Erel and is based on the fact that connective tissue carries genetic message for the underlying epithelium to become keratinized. So which carries? So there is this. The advantage of this technique is that the donor tissue is obtained from the undersurface of the parietal flap, which is sutured back in primary closure, and so that healing also will be by first intention. The patient has less discomfort postoperatively at the donor site. So another disadvantage of the free tissue graft is that the improved aesthetics. So that is, it can be achieved because of the better color match of the grafted tissue to the adjacent areas. So that is the connective tissue graft advantage, and also you can see that this you can see that the continuous photograph is unique because this carries the genetic instructions for the keratinization of the overlying epithelium. So the autograft also allows the graft site to be sutured. So there is the enabling primary closure of the wound. So coming to the apically displaced flap, this technique uses either partial thickness or full thickness apically positioned flap to increase the zone of attached gingiva. So you can see that an internal bevel incision of 1 mm can be made from the crust of gingiva and directed to the crust of the bone. You can see there 1 mm gingival margin. So you can see that this is the internal bevel incision. There is the 40° to the tooth surface. And then you can see that clavicular incision is being made and initial elevation of the flap, then internal incisions are performed. So vertical incisions are made extending beyond the mucogingival junction. So this can be either a split thickness flap or full thickness flap according to the thickness of the tissue. So there is split thickness flap that is elevated using sharp dissection with a BP blade to split it, leaving a layer of connective tissue involving the periosteum on the bone. Whereas full thickness flap, this will be elevated by blunt dissection with the periosteum. So you can see that the wedge of tissue that contains a pocket hole will be removed, and then the flap is displaced apically. So see, you can see that here it is displaced apically, and then the sutures are placed. So partial thickness flap will be sutured to the periosteum under using a direct loop suture, and full thickness flap, if it is, then it will be a sling suture. So after 1 week, the dressings and sutures will be removed and again repacked for another 1 more week. So coming to the indications, contraindications, advantages and disadvantages. Indications are increased attached gingiva in areas with narrow attached gingiva, elimination of pocket that extends beyond mucogingival junction with narrow attached gingiva, crown lengthening can be done. Contraindications, thin gingiva, lack of keratinized gingiva at free gingival margin, narrow oral vestibule you cannot do for it, and extremely thin alveolar process, extensive osseous surgery, and deep intrabony defects leading degeneration. Advantages are periodontal pocket can be eliminated with the width of attached gingiva. So clinical crown lengthening can be extended. That is, crown can be extended while biological width is gained. And what are the disadvantages? Is technically it is very demanding. Danger of penetrating flap during incisions, and it can lead to sometimes necrosis due to the severe damage to blood vessels, and it will be delayed healing. There is a secondary condition. So then coming to the problems associated with shallow vestibule. So you know that with the problems associated with shallow vestibule. So with minimum vestibular depth, proper oral hygiene procedures will be jeopardized. There is a circular version technique, for example, the circular version technique. That is the bus technique requires placement of the toothbrush at the gingival margin, which may not be possible with a reduced vestibular depth. So, in case of minimal attached gingiva with adequate vestibular, may not require surgical correction if proper atraumatic oral hygiene is being practiced with a soft brush. So, minimal amounts of keratinized attached gingiva with no vestibular depth benefit from mucogingival correction. So, that is what. So, adequate vestibular depth is always necessary for the proper placement of removable processes. So the important clinical aspect in deepening the vestibule is proper preparation of the recipient site. So the recipient site must be covered by immobile periosteal tissue. If there is a lack of periosteal, connective tissue, donor tissue may be placed over the bone. So the donor tissue can be free gingival or a connective tissue. Must be placed over a non-mobile recipient. So coming to the problems associated with an aberrant frenum. So what is a frenum? Is the frenum that encroaches on the margin of the gingiva can interfere with plaque like biofilm removal, and the tension of the frenum tends to open the sulcus. So in these cases, surgical removal of the frenum is indicated. So there is a correction of frenal or muscle attachment should be done if that extend coronal to mucogingival. So coming to the frenum, what is a frenum? It is a fold of mucous membrane enrosed with muscle fibers that attaches the lips, cheeks, gingiva and alveolar mucosa. So any tension on the frenum may pull the margin gingiva away from the tooth. So plaque control will be difficult, gingival inflammation. It can result in gingival inflammation, pocket formation, mobility, migration. So coming to the classification, there is depending on the extent of attachment of fibers to frenum have been classified by Placeger in 1974 as mucosal, gingival, papillary, and papillae penetrating. You can see that if it is attached to the gingiva, it is gingival, and if it is attached to gingiva, it is gingival, it is mucosa to the mucosal. And you can see that it is little papillary towards the papilla, and it is the papillary penetrating, it will get extended to the lingual, palatal side. So this can be tested by tension test or blanch test, or you can tell it as a pull syndrome. So there is tension test or blanch test. There is you have to forward and upward movement of the lip. You can see that the tension that is creating over the gingival margin. Okay, there is a tension test, and the blanching. If you are seeing in case of papillary penetrating, you can see that blanching of the tissue in the lingual palatal side of incisive papilla. So that is in case of incisive papilla you can see, and also the pull syndrome is that it is called as there is a marginal tension that is creating with the pull. So with the pull movement, so while speaking or while retraction, you can see that the pulling gingival margin from its original position. So that is called pull syndrome. So coming to the procedures, there is frenectomy and frenotomy. So what is frenectomy? So you know that optomy is the removal, excision. So that is frenectomy is the complete removal of frenum, including its underlying attachment to the bone. So what do you mean by frenotomy? There is a relocating the frenal attachment so as to create a zone of attached gingiva between the gingival margin and the frenum. So the main purpose of these procedures is to relocate the frenum, create a zone of attached gingiva, just apical to this gingival margin that is above the frenal attachment, and also plaque control should be easier. So you can see that this procedure, there are various techniques for frenectomy. Okay, so this is a normal conventional technique. That is, you can see that See, this is the frenal attachment, papillary attachment. So you can either hold with tissue forceps, and you can make the incisions just above and below of this holding forceps. So you can make a incision and remove the tissue. So you can then approximate the area with sutures. So that is the, you can see that this is the, there is a frenotomy done in case of, there is a labial side of lower front tooth. You can see that there is a frenum pull in relation to, there is a main cause for this recession, and you can see that there is a vestibular depth, so you can see that it can be incised apically and you can suture it. So this is the case with lingual frenotomy. There is normal, it is attached from underneath the tongue to the floor of the mouth. So angulosia, when there is lack of or minimal lingual frenulum, or the frenulum is attached to the apex of the tongue, or the tongue movements are very limited. So what happens? So this can be the same way, you can hold it with the hemostat after giving local anesthesia. You can hold this tissue with the forceps, and then you can give the incisions above and below, and you can make a V incision and it can be sutured back. So this is the post-operative view. So coming to the aesthetic surgical therapy. So a missing papilla creates a space that is called as a black hole. Regeneration of the lost or reduced papilla is one of the most difficult goals in aesthetic periodontal surgery. So an excessive amount of gingiva in the visible area. There is a condition is often called as gummy smile. So it can also be corrected by surgically crown lengthening. So these are the two. There is a papillary reconstruction area and the crown lengthening. So internally papilla is gingival tissue supported and created by two adjacent teeth in contact and the underlying bone beneath the tissue. So the loss of bone as a result of periodontal disease or the loss of contact alters the support of the internal tissue, which can lead to loss or reduced height of papilla. So the predictable reconstruction of the papilla is determined by augmentation of gingival tissue, the presence or absence of the underlying bone, and the contact of two adjacent. So coming to the aesthetic surgery, is the most important procedure is papillary reconstruction. So before coming to the surgical procedures, we are dealing with the classification of interdental papilla. Model and Tarnow proposed a classification system regarding the papillary height adjacent to normal teeth. So what is normal? There is interdental papilla occupies entire embrasure space apical to the interdental contact point. You can see this is the normal one. So what is class 1? There is a tip of the interdental papilla is located between the interdental contact point and the level of CJ on the proximal surface of the tooth. So that is the class 1. So coming to class 2, you can say that the interdental papillary tip, it is located at or apical to the level of CJ. So it will be at or apical to the level of CJ on the proximal surface of the tooth, but coronal to the level of CJ mid-buccally. So it will be coronal to mid-buccally, but other than it will be at the level or apical to the level of CJ, but it will not go beyond this buccal area. So what is class 3? There is a tip of the papilla is located at or apical to the level of CJ mid-buccally. So that means it is apical to this point. So that is class 3. So this is the classification given by Notland and Tarnow. So coming to the papillary reconstruction procedure, according to Beagle 1992, he described a pedicle graft procedure utilizing the soft tissues parietal to the internal area. So this is the area that is the lingual side of the papilla. So we will give a split thickness flap here, that is, the dissection is given on the parietal aspect of the internal area, and then the flap is getting elevated labially folded and will be folded and sutured to create a new papilla at the facial part of the internal area. So this is what is getting created interdentally. So then after that there will be a periodontal dressing will be given on the palatal aspect only in order to support the papilla. So this is the procedure that is given by Weigel in 1990. So the next technique, there is a semilunar coronally position flap that is given by Hannah and Dickey in 1996. You can see that there is a cracked triangle due to the loss of interdental papilla. So that is a semilunar incision has been created. There is the mucogingival junction. There is around mucosa and the attached gingiva, and there will be a clavicular incision will be given through this, so that it will create split thickness flap, and this can be pulled out apically to the intestinal area. So then this can be sutured. So then this can be kept aside for 1 minute for getting the hemostasis, and then you can give the surgical dressing. So coming to the next procedure, that is with the semilunar incision that is placed apical to the mucogingival junction. So this is a technique, that is an envelope technique that is given by SE in Italy in 1999. You can see that there is a intergenital papillary lobes black triangle. So every cases it will be just class 1 or either class 2. Class 3 cannot be treated. Okay. So the incision is given with the surgical blade. You can see that semilunar incisions. So semilunar incisions have been given. Then the coronal displacement of the entire gingival papillary using the surgical ophthalmic blades. So this pouch, there is a pouch will be created in between. So for this case, there will be full thickness flap will be raised. So in these cases, you can use platelet rich fibrin. So this being tucked into the prepared pouch, and you can see that this being pulled by the suspensory sutures, and then the frenum pull can be relieved for avoid the tension at the gingival papillary unit, and the periodontal dressing has been given. So this is a barricade dressing given, and this is a postoperative view at 10 days. So next history procedure is crown lengthening. So when there is inadequate amount of crown or tooth structure for the crown to be placed, so we need to do the procedure. So what is this procedure? This is a procedure that employs combination of tissue reduction or removal, osseous surgery, or it can be done by orthodontic extrusion. So for the main idea behind crown lengthening is to maintain the biological width. So what do you mean by biological width? So this is the physiology dimension of junctional epithelium and condylar tissue. Always this biological width of 2.04 mm, the healthy tissue will be covering the bone to protect the bone from bacterial penetration. So this is the measurements. This has to be maintained. For example, if there is not enough tooth structure is exposed, we need to expose the tooth structure by removing the soft tissue. By removing the soft tissue, it will be violating the biological width. So definitely you have to go for the removal of bone, and we have to make the biological width over it, and then you can go for the uh, tooth exposure. So main objectives behind it is to increase the clinical crown height, lost due to caries, fracture or wear. You can see that in this case there is inadequate tooth structure is available for the crown placement. So we have to go for apically displaced flap with the opening of flap. So we will be removing 1 mm of tissue, and also we will be contouring the bone, and we will be exposing it. See, at least 4 mm of tooth structure should be needed for the crown placement. So we will be removing and suturing back to the at the level of bone. So this is also helpful to assess subgingival caries, to assess perforation in coronal third of the root, to relocate margins of restoration that are impinging on biological width, and also for aesthetics. So this will be more clear with the diagram. That is, if it is greater than 3 mm of soft tissue between the bone and gingival margin in adequate attached gingiva, you can see that it is 5 mm pocket depth. So we need 2 mm of 2 to 3 mm of normal pocket depth. So after that you can go for, so 2 mm can be removed for exposing the tooth structure. So that can be done only by gingivectomy. So you can see that if there is only 2 mm of, that is within less than 3 mm of soft tissue between the bone and gingival margin, that is less than adequate attached gingiva, we have to go for bone recontouring for maintaining the biological width and for exposing the tooth structure. For this case, a flap procedure and osseous recontouring are required for crown lengthening. So for the crown lengthening, this is a clinical picture of the procedure. You can see that there is minimal amount of tooth exposure. Here only it has been displayed for the crown placement. So you can see this. So it's been displayed. It's been exposed by using the apically displaced flap. So the flap has been raised and displaced apically. So you can see that the amount has to be removed for exposing the tooth as well as for the biological width maintenance. So you can see that the bone has been removed. So osseous surgery has been done, and then you can see that, see, this is the after hemostasis. So this will be placed back at the level of bone. This will be sutured back. This is your occlusal view, and this is a post-operative view after 1 week. And after 2 weeks, it got the temporary restoration and then the crown placement. So then coming to the next aesthetic surgeries or the tissue engineering. So we have covered the aesthetic surgery part by crown lengthening and papillary reconstruction. Then coming to the next level of perioplastic surgeries are tissue engineering. There is a future of periodontal plastic surgery will encompass the use of tissue engineered products at the recipient site to reduce donor site morbidity. So results of numerous experimental and clinical studies support the clinician's use of a minimally invasive approach to periodontal plastic surgery. So there is augmentation from edentulous area that is coming under tissue engineering procedures. That is, you can see that this augmentation, the soft tissue or hard tissue augmentation can be done in case of loss of soft tissue or hard tissue. So in this case, you can see that there is a loss of soft tissue and hard tissue in relation to this tooth. So that is adjacent to the coast tooth, there is a area of edentulous area. So this can be used for augmenting this area. So there is a 15 blade is used to make a V-shaped incision and not involving the furcation area. So it will be like tapered towards the side. So but far enough apically to include pockets if any. So then a partial thickness flap is plain here, and then oblique incision is made rather than straight, so that it permits a rotated flap. You can see that. So this is a mucogingival junction. So this is the recession area. You can see. So this being augment, this area is planned to augment from the edentulous area. So this being the donor site is being created. There is a pedicle type of flap is being created from the edentulous area, adjacent edentulous area. So the incision is extended along the crest of the edentulous area and a full thickness flap is planned. In case of inadequate attached gingiva, the parietal aspect of the ridge is included to increase the area of attached gingiva. So in case of inadequate attached gingiva, you can use the parietal area also for increasing the width of attached gingiva. So you can see that this pedicle is dissected with the number 15 blade being moved in an apico-occlusal direction. So you can see that the full thickness flap is being raised from the edentulous area and is being shifted to the area of recipient side. So one split is reflected forward, freed from underneath the scalp using the scalpel. So the flap is reflected and beveled out. Incision is added. So this beveled out incision can be added towards this point, and this it can be shifted to the area where they need. That is, flap is repeated and beveled out incision is added to fixed recipient portion of the V-shaped incision to prevent overlapping of the donor pedicle. So always it will be a V-shaped incision, so it won't get overlapped over this tissue. So then sutures have been placed. You can see clinically also, you can see that this is the V-shaped incision here created, this being transferred to this area. Soft tissue augmentation. So coming to this soft tissue augmentation, the latest one is what we are using is the SLR dermal matrix allograft, originally intended to cover burn wounds. Has been introduced as a less invasive alternative soft tissue grafting by Silverstein and Callan in 1997. So this allograft is a freeze-dried cell-free dermal matrix composed of a structurally integrated basement membrane complex and extracellular matrix in which collagen bundles and elastic fibers are the main components. So what are the indications for this? Especially that is for soft tissue augmentation, multiple adjacent gingival recessions, lack of graftable parietal tissue, patient reluctant to have a second surgical site, correction of gingival or mucosal tattoos. So you can see that this is areas is a multiple recession defects. So it has been there is alloderm has been placed inside the by creating it as a pouch and has been coronally placed. So this is the post-operative view. So coming to the ridge augmentation, so this can be classified. So coming before going to the ridge augmentation, we will classify the ridge effect. So according to the classification, we will be planning the treatment. So according to CBER 1983, what is class 1? There is a buccolingual loss of tissue. There is a buccolingual loss of tissue that is treated as class 1. This is a very common ridge defect. There is a buccolingual loss of tissue with a normal epicocoronal ridge height. So epicocoronally will be normal, only the buccolingual width will be less. Whereas class 2 is epicocoronal loss of tissue. There is epicocoronal is loss, but the buccolingual will be normal. Whereas the third one, there is a combination, there is a both buccolingual and epicocoronal loss of tissue. You can see that this is the major defect. There is a class 3. There will be loss of both height and. So then coming to the prevention of ridge collapse. So before there is we have told about the ridge defect. So to avoid this ridge defect, always we can go for socket preservation. So this is the cross section of a tooth extraction site. You can see that this is the area after extraction. So this can be filled with grafting, a traumatic extraction followed by the placement of graft inside. And after that you can place the GTA membrane and closure of the flap. See, this is a bone graft placed to form the bone, and so this is the final formation of bone. So it will take at least 3 to 6 months for the proper bone augmentation. So there is another technique. There is a pouch procedure that you can see that the you can take only a pouch will be created inside, and this and a tissue tissue can be taken out from the parietal side or from the other side, then can be taken as a pouch. So this can be used as platelet rich fibrin also, or alloderm also can be used. So it will be like a pouch, it will be sutured and it will be taken out inside that and will be sutured outside. See, it will be sutured outside. So the occlusal view will be like this and the buccal view will be like this. So you can see that there is a direction of ridge. There is both there is a buccolingually adequate and apicocoronally less. So you can place the bone grafts here. GTA membrane has been placed and then closed. Coronally displaced flap. So this is the view after the bone formation, and this is the after the crown placement. This is the view. So you can go through some of the surgical procedures and related to the class 3, and this is the class 2. We can see that usually for class 1 we will use for pouch procedure for tissue augmentation, whereas for this class 3 you can see that both amount of augmentation is needed, bone graft as well as soft tissue augmentation needed for this case. That is, you can see this is the result. So in case of class 2 also, you can see this is the other procedure that is being created. That is, tissue will be, so this is epicocoronal loss, it is a class 2. So you can see that bone graft will be placed and the soft tissue will be placed over it. So this is after the crown placement, and you can see this is the post-operative view. So there are soft tissue procedure around implants also. So in place of inadequate amount of width of bony hard tissue, there is a bone tissue. So this can be augmented by bone grafts and the soft tissue for widening the width of ridge. You can see that here it is being augmented by using soft tissue and hard tissue. So after 3 to 6 months you have to take radiograph again. If there is adequate amount of width and the bone level, you can go for uh, there is implant placement. So this is the implant supported processes. So you can see that here in case of There is a buccolingual loss. So this has been augmented here. So that is with the pouch procedure has been augmented. An apically positioned flap is used to expose an implant while increasing the keratinized tissue. So here they have used a apically displaced flap to increase the attached gingiva. You can see that there is a loss of attached gingiva. And then this internal brush has been advised for the oral hygiene maintenance. So this is the post-operative view. Coming to the surgical exposure of our unnerved teeth for orthodontics, you can see that this is the tooth, there is the underlying dental tissue, that is osseous dental tissue. So this is being uncovered by this procedure, uncovered, and by using orthodontic movement, it can get placed to the normal position. This will be covering first and second part of mucogingival surgery.